Welcome back to The Thinking Mind, a podcast about psychiatry, psychology, psychotherapy, and self-development. Today we're going to be talking about what it's like to be in an extreme state of mind and what psychiatry can do to better understand, treat, and help people when they are in these extreme states. With us to have that conversation is Dr. Patte Randal. Dr. Randal is a doctor trained in psychiatry, now retired from practice after working for over 30 years in mental health. She has a lived experience of recovery from psychosis. She's told her story publicly in many contexts, including in her published book, Finding Hope in the Lived Experience of Psychosis, which she co-authored with Dr. Josephine Stanton. Obviously, it's extremely valuable to have a guest on who has been both doctor and patient. And today we discuss Patte's experience with psychosis, what it was like for her to have that experience, how it was treated, and crucially, what these experiences may have meant for her psychologically. We then go on to discuss how these experiences influenced her approach to treating patients with similar issues like psychosis, manic states, etc. Patte makes a strong argument for a paradigm shift that we need in psychiatry, and we try and make that shift as concrete as possible in today's conversation using a clinical example. Otherwise, thank you again so much for listening. I hope everyone out there is having a good summer. If you haven't yet, do check out the new Thinking Mind blog. That's the monthly companion newsletter to the podcast, which we're publishing on Substack, and we hope to publish some Substack posts in between as well. The link for that is in the description. As always, you can direct any and all feedback about the podcast to thinkingmindpodcast@gmail.com. We've had some lovely fan mail this week, and we always love getting more. But even if you have some criticisms, don't hesitate to reach out, ways you think the podcast could be better. If you like the podcast and you want to show some appreciation, the best way to do that would be to follow or subscribe on whatever platform you're listening on, leave a rating or even a written review, and share with a friend. Thank you very much for listening. And now here's today's conversation with Dr. Patte Randal. Dr. Randal, thank you so much for joining me.
It's good to be here. Thank you for inviting me.
As we were discussing offline, I always find it incredibly valuable to have guests who have some kind of lived experience to offer and share with the listeners. I was discussing that we recently had a guest on who was talking about their experiences of bipolar. In your case, even more valuable because you're also a doctor trained in psychiatry. You've seen people themselves who are suffering with mental health conditions. So your perspective, incredibly valuable. I actually haven't read too much about your story because I wanted to hear it from you. So maybe you could tell us a little bit where you think your story begins, where the best place to start is.
I often say jokingly that I started my training in psychiatry when I was born, actually. But I won't go into detail about that at the moment. But I think we do learn along the way, you know, that what happens to us forms us.
Yes, absolutely.
And I had my first extreme state episode, which I felt and experienced as a mystical experience, which came completely out of the blue when I was 24. And I had begun my training in medicine. I'd got married. I started my training at the Middlesex Hospital in London and was moved to Sussex University to do a neurobiology degree. And I had a baby. My father died, my marriage broke up, and there were a couple of cot deaths of children at the university. And the other thing was, this is the this is a context in which this extreme state happened. I was being training as a psychiatrist and a doctor. I was doing my PhD by then, looking at the pulse diagnosis in traditional acupuncture. So a whole completely different worldview, reading Taoism and et cetera, And with all these other things, it's almost like the whole structure of my life collapsed. And my marriage was breaking up and a number of things were happening. And suddenly I found myself in an altered state of consciousness, a different reality. And I experienced dying and being reborn. And I experienced being in the vanguard of a massive change in culture and society and pulling people through into this new reality with me. it's a completely new reality for me. And suddenly I was experiencing this extreme state. And I wasn't sleeping and I was behaving oddly. And I ended up in the student health service under Dr. Anthony Ryle, who at the time was running the mental health service at Sussex University. He was a GP. He subsequently went on to develop cognitive analytic therapy and has become very well known. But at the time, he was 48, I was 24, and he was the lead person at the health centre, and they admitted me there, and I ended up sleeping on cushions on the floor because it was such a weird experience and so strange.
What did you think was happening when you were admitted?
I knew they were taking care of me. I mean, I knew that they were trying to take care of me, but I was in a very, very different state. And the nursing staff there, I mean, they were trying to look after me, but I was obviously behaving very oddly. I was being very childlike, apparently. And they were quite tough on me, actually. They sort of said, stop behaving like a child. They didn't realise how unwell I was. They thought it was sort of within my control. And so I mean, I didn't really know. As I say, I felt I was having some kind of mystical experience. Not that I had a worldview that contained mystical experiences. I was sort of, brought up in a sort of atheist, agnostic context. There wasn't, that bigger picture. Even though my mother was Jewish, born in Palestine, actually, one of the first Jewish children to be born there, but we weren't brought up in with a spiritual worldview at all at the time.
In terms of the mystical experience, I'm aware that can feel very positive or very negative for people, or can feel, doesn't necessarily feel pleasant. For you, how did it feel emotionally?
I felt I was traveling on the edge of time. That was an experience I had. And it was an elating feeling. It was absolutely an elating. It's like everything had changed. And actually the thing, I mean, again, bringing it all back to mind as I'm speaking, I felt that even gravity didn't exist anymore. And at Sussex University, there are very steep steps going down, it's in the South Downs, so it's very, very steep steps. And I was standing at the top of some steps and I saw some people walking past. For some reason, and I can't remember exactly the reason, but I stepped off because I felt there was no gravity anymore. I stepped off the top of this very high steps, thinking I would just float to the ground. But of course, I didn't float to the ground. I fell to the ground. And as I hit the ground, I felt as if all my bones had broken. But I looked up and I saw these people going past and I thought, oh, they think a miracle's happened. And I jumped up as if a miracle had happened and as if all my bones had been fixed. I ran through the campus, hugging everybody and saying, we're all the same, we're all the same. We're all sort of superhuman people. We're all godlike. And everybody seemed godlike. And I went racing along the corridor and opened the door of Anthony Ryle's room, thinking that I could just go in and see him because we're all the same. And, why do we need to be in therapy? Because we're all godlike. So that was his first realization that I'd flipped. But I was completely elated because I felt so connected with everybody and I felt the godlikeness of our state.
How long were you in hospital for on that occasion?
It wasn't hospital, it was the student health service. Right. And I was only there for a few days. I mean, I was only in there for maybe 3 nights I can't really remember, actually. I probably remembered more when I'd read the book. The detail in the book is more accurate than my memory currently. But I was given chlorpromazine. He prescribed me chlorpromazine, which at the time was, a typical antipsychotic, as they called it, which obviously was what they used in those days. And immediately I started to feel very unwell with it. And actually, I didn't think I needed any medication. I just needed to sleep. And I was sleeping reasonably well after the first couple of days. Probably the chlorpromazine did help with that. But I noticed it was making me feel very sick. So I hid it. I hid the medication in a tissue paper, and I settled down quite quickly, actually. Well, I think I wasn't behaving in my usual way. I was much more sort of out there, because I'm usually quite shy. I'm usually quite socially shy. But I obviously wasn't still in an extreme state. And so after a few days, he felt, the medication was helping. And I showed him my tissue paper and said, I haven't been taking the medication, so I must be okay.
Yes.
Unfortunately for me, Anthony Ryle, who was a pretty amazing person, actually, he didn't force me to take medication. He allowed me to go home.
Just recover spontaneously.
The problem was, of course, I'd had this very extreme, severe side effect from even taking 3 tablets of chlorpromazine. And I developed chlorpromazine jaundice, as it was called in those days, which was a very rare but very serious side effect of taking chlorpromazine. And I ended up having, going yellow and being very sick, and having to be admitted and having a liver biopsy and et cetera, which brought me down with a crash.
And then was that the only episode you have where you were in an extreme state? Did you have any episodes after that? Then
after that, I didn't have any more episodes for 12 years. So I, a single parent, finished my PhD, go back to medical school, finish my training in medicine, become a GP, marry my second husband, have another baby, 12 years of getting on with my life. And then we came to New Zealand and I had a second episode 12 years later. And I've had 8 episodes altogether. The last one was in 2003. So I haven't had an episode since 2003.
Were they all triggered by stressful experiences like your first one?
Yes, I think so. They were all triggered by lots of things changing at once and things that were very distressing to me because of my journey, my story, that wouldn't necessarily be particularly stressful to other people. But they were all triggered by things that were stressful.
Stressful situations. And were they of a similar character, as in feeling like you're having a mystical experience, standing on the edge of time, kind of like supernatural type phenomena?
Yes, they were. They were like that. There was it was always intense meaning, and synchronicity experiences, sort of things, meaningful coincidence lining up.
And already in my psychiatrist's brain, like part of me wants to ask kind of what I would think are like trite questions, like were you hallucinating, or was there any like self-harm, or what medication worked, or was medication a factor? And I guess these questions are important to a degree, but I'm also interested in like what's the meaning you make of those experiences? Like what do those experiences mean to you?
Well, I think that's a really good question, because they to me, when I think about them now, they were all sort of dream-like experiences. It's like when you have a dream, there's meaning in the dream, but it's not direct meaning. It's symbolic or metaphorical meaning, and you often need help to figure out how the pieces all fit together. That's how I do believe that many of these extreme state experiences that people have, even though they have very bizarre content, there's very often you can put the pieces of the puzzle together. In fact, one of my experiences, I had this very vivid experience of this cosmic jigsaw puzzle. That when I was in this extreme state, it was like this cosmic jigsaw puzzle with all the pieces thrown in the air, and that I somehow was going to be able to put all those pieces together, which was very terrifying, actually. It was like seeing too much. And the odd synchronicity that followed that extreme state was that I'd had this visionary experience in this altered state of consciousness and of jigsaw puzzle pieces. And then I came home and my boys had tipped all the jigsaw puzzle pieces on the floor. And there were about 10 different children's jigsaw puzzles, which were all meant to be separate, and they were all tipped on the floor. And we had to all sit together and separate out the different actual literal jigsaw puzzles on the floor. So this kind of odd synchronicity type thing has happened quite a few times for me. How does one make sense of that? I don't know.
It sounds like you were trying to figure something out, some sort of important questions.
100%.
What were you trying to figure out, if you're comfortable sharing it, of course?
Well, I mean, I think on some level it's like trying to figure out the meaning of life in some ways. What are we doing here? And how do we make sense of these things? I didn't realize until much later in my life, till I was about 47 actually, that some of the things that had happened to me as a child, which really damaged my trust, were at the root of, the extreme state experiences that I had. And I've talked about that in the book. I was trying to figure out how to make sense of my, growing up experiences. And I suspect, in retrospect, and I don't know about this, but my mother's Jewish. She's died now. But, and we've recently found that a whole side of her family perished in the Holocaust. And then she was brought up in what was then Palestine, became known as Palestine. There was a lot of avoidance and denial. They trying to reform a whole life there, and as we know, there's horrors going on there now. And I think she learned to cope by avoidance and denial, and never spoke about some of the things that had happened, or she possibly didn't even know about them. A lot of things were not talked about, and so we grew up with this sort of not really being able to express our feelings and always having to kind of somehow take care of our mother. And I mean, I had very loving parents, but a father who never talked to me, a mother who was very vulnerable and anxious, but also very, very able. And it was hard to figure out. It was hard to figure out what had really happened. And also the Jewish thing of being, although we were not brought up with any religious practices, the Jewish thing that she had with her was the chosen people, the special people, as if we were different. And one of the things that came out during that first episode, I was running along saying, we're all the same, as if we're not different. We're just the same. We're all the same. So it was an attempt to sort of, figure out who one can trust and how one can trust and what are we here for and what's our purpose, what's the meaning of all these things.
That makes a lot of sense. And saying that, I'm thinking, when people present with stuff like psychosis or manic episodes, we very rarely ask them as psychiatrists, what's the meaning you make of those experiences? We never really try and interrogate the symbolic value of one of these episodes. We might do it with a dream. So if a client, especially in psychotherapy, if a client comes with a dream, we don't say, okay, you were dreaming. That's a, form of mental illness that it's not worth paying attention to at all. We say, okay, you were dreaming. Obviously, the dream itself isn't literally true. But if you were dreaming about being alone in a house and encountering some figures within the house, we might say, what's the symbolic value of that? We could do that with these kinds of states as we're doing now, but we don't.
No, exactly. And I was very struck by that when I first started doing psychiatry. I mean, I found that I had a natural inclination to work well with people who had mental health issues. And I just knew that what they needed was to find the meaning in what they'd gone through. And I had a kind of, because I'd had that first episode. And yes, I mean, in fact, I'm part of this international group who are called the International Society for Psychological and Social Approaches to Psychosis, who've published 2 books, which I've got 2 publications in their book series, who are all about finding the meaning in these extreme states. So there is a group of us, a small group of us in the world. But when I first started to study psychiatry, I was very horrified that we were only listening to people to get the form of what they were saying rather than the content of what they were saying. We weren't trying to help people develop their narrative at all. We were trying to diagnose all the time by listening only for the oddness in people's ways of talking.
And even, so you're making this really crucial distinction, which we made earlier, between content and process. So like, what's the content of someone's, let's say, beliefs versus the fact that they are having beliefs which might not be literally true or literally in keeping with reality. But even as we've been discussing a little bit about your history, which you've been kind enough to share, even the fact that that process is going on is useful. So we might ask, okay, if someone is having like a psychotic-like episode, what might be going on in their family system that might cause such an episode to arise? But we don't ask that question either. So one of the problems is in psychiatry, we would typically, if someone's having an episode like that, say, okay, you have basically a brain-based mental illness or disorder, basically locating the problem in that individual, for better or worse. And again, so much useful, interesting questions, you could ask, not necessarily in a blaming way, like whose fault is it, but what's happening in this person's family system, culture system, generational system that might be contributing to an episode like this.
Absolutely. I believe that's how we need a paradigm shift in psychiatry, I believe. And actually it's funny because I go back to that first episode and think of me believing I was, or seeing myself in the vanguard of a movement and pulling people through into new reality. This is I now can see it through the lens of, well, this is the lived experience movement. This is the paradigm shift of making sense of our lived experience and supporting one another to do that, which is helping to shed light on all sorts of aspects of what we value in life and what we're here for and how to support one another to have a meaningful, hope-inspiring life, which can so easily get ripped away from us if we're caught in the stigmatizing and discriminatory frameworks that psychiatry often imposes and culture imposes.
Did you end up training in psychiatry because you had that first episode? Was that a big reason why?
I think it's because I found I could work so well with people and I was working in a different way with people. And I felt that was what I was really called to do. I mean, I felt I had something to offer in psychiatry, which was because I'd had that first episode. I wouldn't have known how to do that, except I knew I'd recovered from something very extreme. And I mean, although I hadn't put all the pieces of the puzzle together, I think I've more so done it now, but it's taken a lifetime. I didn't really get enough help to do it. Even Tony Ryle, who was so wonderful in terms of his capacity for being with me in a healing way. Those days we weren't putting together sexual abuse, trauma and what it leads to, etc., etc. We didn't really even know how to get the story. We do. We much more so now. We do, but we weren't even really getting that story properly.
I think the other thing that's really important when it comes to not just being a good psychiatrist, but being a good doctor is to realize when you're sitting opposite a patient, you could be that patient very, very easily. And that's the case with a physical health condition. Your patient opposite you has nephrotic syndrome and illness of their kidneys. If you were born with their genetics and their environment, you would have nephrotic syndrome. And again, in psychiatry, I don't think it happens, as often, but I do see instances where psychiatrists, act almost as if they're above having a mental health condition, somehow above having depression or psychosis or what have you. Obviously, having had some kind of episode yourself, you didn't have that kind of illusion. You're like, yes, I am the same as you in some fundamental sense.
That's absolutely right. And in fact, what emerged out of that for me, if it's all right for me to carry on just talking as I talk, was this concept of building a bridge of trust, which is in the gift box that I've talked about. So this idea that we all have our own story. And even in our professional training, part of our story is what we've learned in our profession, and different professions have different stories, different experiences and so on and so on. And in a way, we need to learn to put aside that sort of pathologizing perspective, where there's a real sense of power over, so that it's not a flat bridge that we're building with people, but it's a power dynamic that where we feel we need to take power over the person. But what we're actually doing is we're putting ourselves in the shoes of the other person, and they can put themselves in our shoes too. That we can put ourselves in one another's shoes, as you're saying, because we're all human, we all share the human condition. So that became a very important concept ultimately became the gift box, which is, as my story unfolded, that's what developed as the resource that has come out of my lived experience and the lived experiences of many people who I've worked with and learned from.
I'd like to ask more about what you see are the problems with, let's say, psychiatric culture and the paradigm shift that needs to happen. But first, I'd like to, let's say, give the devil his due. Is there any value, do you think, in the episodes you said you had about 8 episodes of being in an extreme state? Is there any value to seeing that through a medical lens, do you think?
Medication is very helpful for some people at some times. It also has lots of really serious side effects. And I think we need to learn more and more about how to use it wisely and as we were all taught as medical students. Judiciously, which we don't do. And we, that unfortunately, we're very risk averse. And the trouble is when we tend to not be keen on responsible risk taking. We try to switch everything off so that we can all kind of hunker down, which is kind of avoidance and denial on everybody's part, actually. We're trying to kind of just stop it rather than seeing the value in supporting it and taking it through to its meaning-making conclusion. But if there is a place for, understanding what's going on and giving it some kind of descriptive label, people do find that very helpful too. I mean, I can see myself through the lens of having had 8 brief psychotic episodes. That also makes sense. And taking medication for that was useful. But actually, in retrospect, I realised I didn't need antipsychotics, which aren't really antipsychotic. They used to be called major tranquilizers. So I needed my limbic system to be, my fight, flight, freeze system to be regulated a bit more, which I didn't know how to do at the time. And the medication helped, especially through helping me sleep. So, I think psychiatry needs to become much more inclusive of all sorts of modalities, not just the pharmaceutical modality, which needs to take it's got a tiny place. Pharmaceutical industry, if it weren't all about making money, if it were actually about really supporting well-being, we would be finding all sorts of new ways of doing that with the biochemical rebalancing of things. But it just all needs to be much more nuanced and, sort of much more, just taking account of many more aspects of our physiology and our anatomy, and, which is what psychiatry tries to do. So it certainly has a place. It just needs to become more sophisticated in a way.
Yeah, I've often talked about, I think one of the major problems I have with how medication is used in psychiatry is it's just used too much, like a blunt instrument.
Yeah, it is used too much as a blunt instrument, absolutely. And it's dangerous for people. It's harming people. It can be. It's not always, and if it's used in this nuanced way, it's very helpful. But if it's not, it harms people. We know that, don't we?
I'm interested in what you were saying about risk aversion. And I'd like to expand on that a bit for the listeners, because I think it's a really valid point. I see this, at least in psychiatry, where I practice in the UK, We're incredibly risk averse. We're very worried about anything going wrong with a patient. That could be some form of self-harm that's not lethal. That could be suicide in extreme cases. That could be harm to others in extreme cases. Or it could just be, the patient not doing well. The way I see it can be a bit controversial, I suppose. I think avoiding this risk-averse culture, which I do think is quite negative, necessarily involves giving more responsibility to the patient sitting across from you, and obviously having the facility to support them so that they can make the best decisions possible. But fundamentally, one of the problems I see with the culture of psychiatry is we take on all the responsibility of ourselves because we're terrified of anything going wrong. And therefore, the way out of it necessarily will involve, and this might include at a legal level or a political level, giving some responsibility back to the patient. Listen, your decisions that you make in most circumstances are your responsibility. Do you agree with that reasoning?
Yes, I do. But I also think it's not just the one-to-one. It's the whole system. It's the whole family system. It's like with an approach I really have appreciated is the open dialogue approach that was initiated in Finland by Jaakko Sekula and co., where everybody is involved. It can be involved in the conversation as long as you can make it a safe conversation, and everybody can help everybody else to take more responsibility for understanding what's happening and changing the process, which also the gift box does that. That's also what the resorts that we've developed helps people to do that with one another, so that we understand much more clearly the chain reactions that lead to the crises that can then become the opportunities to create from vicious cycles to victorious cycles. Where people can take self-responsibility because they've got much more understanding of, and they're not told what to think, but they can actually get to see options of what actually has happened and how to make it, because everybody would choose to be in a victorious cycle if they knew how to change their behavior and their thinking. We would all support one another to do that. We just need the tools to allow us we need the tools to facilitate that process, which if you don't have it, the psychiatrist is in a really difficult position. And you've got to be able to sleep at night yourself.
Yes, and that's why I love talking to you, because you're also, besides having had first-hand experience yourself, you're able to represent that other side of the coin, which I think is not represented enough in these situations, which is psychiatrists and doctors generally are in really difficult situations. We have to make, at times, very difficult decisions, sometimes at 3 a.m., sometimes when there is a lot of risk involved. And it's very tempting to fall into the trap of being a little bit paternalistic with your patient and taking a lot of control, because you're being faced often with a lot of chaos. And it's a difficult situation that psychiatrists find themselves in often.
Totally. And I think in the acute situation, it's often absolutely the right thing to be doing, to be prescribing whatever it is that's needed in the moment. But I mean, there are lots of other ways we could be going about it as well, which we don't really have access to. And if only we did, because it's actually not rocket science. We actually do know how to hold people safely in environments. We just need those environments.
I'd like to zoom in on that. So we need to make a distinction about timelines. If someone's unwell or they're having any kind of extreme experience, the timeline is important. What you do in the acute situation, what you do in the medium term, what you do in the long term. As the time horizon extends, you do, generally speaking, have more options to work with. And perhaps we don't normally take advantage of that.
I think that's true. And I think we don't go through the detailed process that each person and their family members need to go through to figure out what's happened and to how to prevent it from happening again, which is a very detailed sort of self-awareness training, if you like, for the person. We don't provide it. And I believe that's what we have developed that we can provide. And the other side of it is taking a more narrative approach rather than a pathologizing sort of power over, you're going to do this kind of approach. So So we're drawing out the person's own strengths and resilience that they themselves have, which we, as psychiatrists, often we don't even listen to it. We don't even look for it. My co-author in the book Finding Hope in the Lived Experience of Psychosis, Josephine Stanton, is working on developing that narrative or helping people to understand and use that narrative approach more. As is a friend of mine who I've just read his book called How Not to Be a Doctor, John Lorna. That's a real confirmation synchronicity for me that that's the right approach. And his work's really worth reading, as is Josephine's, which is on our website.
I'd like to paint you a little bit of a picture, maybe a bit of a clinical picture, and you can tell me like what would you be worried about happening down a, let's say, more conventional path, and then what would be importantly different with the framework you and your colleagues have established. So imagine, I'll ask the listeners to imagine a 20-year-old man who perhaps was under a lot of stress at university, say, and gradually became more and more withdrawn, had difficulties doing his exams, and ended up having, a set of unusual experiences. He was hearing voices. He started to believe that people were following him, and things came to a head. He was admitted to hospital. I mean, I should say this is entirely fictional, but it's the kind of thing we see a lot in psychiatry. Perhaps they were admitted to hospital for a couple of weeks, started on some antipsychotic medication, and now the medication seems to be doing what it's supposed to, and they're getting better, and they're starting to recognize those experiences weren't sort of literally mapping onto reality, and they're going to get discharged in a few days. So first, I'd like to ask you, in a situation like that, what would you be worried about happening conventionally in psychiatry? And then maybe after, you could tell me what your framework might importantly do differently.
Yes, lovely. Well, I mean, I've worked with people exactly like that, so it's a good example. Yeah, I'd be worried about a number of things. I'd be worried about that person being sort of told they've got to take medication for possibly the rest of their life, or even just for 2 years, them finding that actually the medication really sort of shrinks them, because I've had antipsychotic medication, and even a tiny dose made me feel shrunk, like I didn't have the creativity and thinking and so on and so on. So I'm imagining that would happen to this young man. He'd start putting on weight, because a lot of these medications do that. He would be although he and his family would sort of, oh yeah, it helped me. If he didn't have any more symptoms, he'd come to a place where he'd think, oh, I don't need it anymore. And he'd stop it himself. And depending on what the medication was, he may well have another, if nothing else had been done to help him understand how this had happened, he may well have another episode. And then he's likely to get even harder kind of control over him. And if that went on, which it does, vicious cycle, with the wrong kind of responses, people get caught in, they get caught on large doses of medication with no framework for understanding what's happened or an ability to come off it. And that happens frequently, and with all the physiological damage that does. And yes, maybe they don't then hear voices or have another psychotic episode, but they're very shrunk down. Can be.
I love thinking about things in cycles, because cycles, or I often use the word spirals, like negative spirals or positive spirals, they really help us understand how different factors affect each other and compound. So, for example, if I was trying to help someone get healthier, I might look at sleep, nutrition, and exercise, and I might explain that all of these things will improve each other. So I might explain, you sleep better, you're more likely to exercise and eat healthy. You eat healthy, you're more motivated to exercise, and you'll probably sleep better, and so on. In this kind of a situation, psychosis is often a lot about safety, and the less safe people feel, it would seem to me, the more vulnerable they are to having something like a psychotic episode. Now, the problem here in terms of interacting with mental health services is if every time you show symptoms, you're also in danger of being sectioned, I'm not saying that as someone who's anti-sectioning in the right circumstances, but if when you show symptoms, you're sectioned or possibly given medication against your will, then you associate getting help with danger. The danger itself might also increase your chances of having an episode and that sense of threat and not being able to trust people. So I think that's a huge piece in what goes wrong. As you're saying, this is the vicious cycle that happens.
We have a page in here that explains exactly what you've just talked about, which is the trauma-informed sequence of events that happens to people because of the dangers that they've. I mean, we usually only see people because they've been a danger to themselves or others on some level. That's how they come into service. And then if we respond to them in ways that make them feel like the things that they don't even know have triggered them in the past, or even if it wasn't clear-cut trauma, it becomes a traumatizing experience, then we trigger in the present what we're trying to help people recover from. So this helps people understand exactly that process, because we don't explain that. We don't explain the sequence, and we don't even understand it ourselves often because we're so risk averse.
So if we go back to the 20-year-old man, what's the best possible outcome for someone in that situation?
Well, I think for that 20-year-old man, what we can do with him and his family is help them understand that spiral, whatever the underlying things are. We don't even necessarily, he may begin to understand what his triggers are. He'll begin to understand the things that he does and the ways that he thinks, because we'll give him some tools to be able to articulate all of that and figure it out. Because even though people often can't come up with the idea, but if you give them some tools to prompt them, people know. They know themselves, or other people can help them know, and they can work out what that chain reaction was that led to that. Like you're saying, they need something to help them sleep, and they need more exercise, and they need good nutrition, and they need ways of distracting themselves and they need to be able to think about their thinking, etc., etc. Or you can provide a context where all of that becomes available. That's what the gift box does, actually, individually and in groups. And often what we found actually is that people will say, oh yeah, I know that now. And they have these aha moments and oh yeah, I know and then of course what happens is they go around again. Because we often think we know, I thought I knew. Okay, I know how not to get into a vicious cycle again. I know how not to make that happen. But it happened and happened and happened again, which it does. But it doesn't mean you've got to give more and more and more medication. You just need to go through this process again and again and again.
Sometimes you just need to learn, as is the case with addiction. I'll often say something like relapse is kind of a part of recovery.
100% it is. Exactly. The worst things can turn out to be the best things if we can understand, if we can support one another in understanding what the patterns are.
Another thing I worry about very commonly with psychosis, you see what's called paranoid psychosis. So people being basically very worried they're going to come to harm or someone is surveying them. I often think about pattern recognition. So we have this wonderful human brain, which is really good at picking up patterns, but not always where they actually exist. In fact, people might know, if they know a bit about cognitive neuroscience, there's two kinds of cognitive errors that you can make. One error is seeing a pattern where it doesn't exist. And the second error is not picking up on a pattern which does exist. So you might see like a rustling in the bushes and you might think, okay, there might be a predator. Every time I see those rustling of the bushes, there's a predator behind those bushes. And I do think, human beings, generally speaking, evolved to see patterns more. We evolved for that bias. In general, we tend to see patterns because it tends to keep you alive a little bit more. And that's really what paranoia is. It's like, oh, I see my neighbor looking at me. And maybe I also then jump to the conclusion that they're thinking something negative about me. And then perhaps that might go to, they want to harm me in some way. Perhaps you're better off, you're likely to be more safe if you go down that line where you think, rather than thinking nothing's wrong. And so this is a very long-winded way of leading to how important is it to have a community around you that feels safe to prevent and treat psychosis?
Yes, I think that's very important anyway, to have people who understand one another and can support one another, as well as being able to understand what the mechanism that's going on that you've just described, which I call a faulty alarm system. It's like a smoke alarm going off, when the kettle boils.
Are you aware of the work of Randolph Nesse?
I'm not sure that I am. No, I don't think I've heard of that.
So he's an evolutionary psychiatrist.
Oh, yes.
And he's a big proponent of using evolutionary theory to help explain psychiatric phenomena. And he actually has a principle called the smoke alarm principle applied to panic attacks.
That's parallel process. But I think when people come to understand that about themselves and begin to notice body, you see, I call very early warning signs are changes in our body sensations. And often we just are not noticing our body sensations at all. If we can teach one another that's where mindfulness comes into sort of everyday life and how important it is to notice the very early warning signs. Like for me, pressure in my chest. I had no idea about that. Or breathing, sort of learning to breathe properly. People think, woo, breathing, but actually it's vital to breathe properly. And I learned as a very young child to hold my breath so that I wasn't crying all the time. We learn to, and that makes us actually much more vulnerable. So, being in a context, there's so many aspects of what makes a safe, secure context, isn't there? Right from the start of life. And forming communities that can support one another, vital. What we find with these groups that we run now, we're using the gift box, is even in a forensic service when we're using the gift box, people start to become more respectful of one another because they learn to be trusting of each other and learn to build trust with each other. It's step one. It's the first healing principle. So, being in safe, secure environments, which is about trusting, not locked secure environment, but free, trusting, secure environments where security is on the inside, not on the outside, which we can do. I feel confident that we can do it. And some countries are better than others. It is a culture thing.
Who do you think, is there a country that's leading the way in terms of a more sophisticated, more nuanced way of treating these kinds of conditions?
Well, people have talked about Triest, the Triest Model, that's right. So they've talked about that, which is sort of on these lines, I think. I think so.
Yes, and you mentioned open dialogue in Finland.
Yeah, in Western Lapland. It's not the thing is, it's these microcultures actually where things can change. So Western Lapland apparently developed, this open dialogue, and the diagnosis of schizophrenia really fell in that little small culture because people were dealing with it so differently. But the whole country wasn't doing that well, as far as I understand it. I don't know where things are up to now. But then when you try to do randomized controlled trials using, as far as this is, as I understand it, open dialogue in different places, like in London or somewhere, the culture itself is so different that the way it's practiced doesn't necessarily give the same results. It's tricky, How do we form those really solid, safe, trusting communities?
And then how do you account for other things like disturbances in the family home,
exactly,
gang culture, recreational drugs, all of which will form a part to play?
That's right. And yet, you see, I think what I believe is if we can be educating children and families to have a framework, this framework that we are talking about, which I believe what you're saying is very, very similar to what's actually here. That we can create tools to support greater conscious awareness of how we develop these patterns, why gang culture happens, how all of that stuff. We can. I believe we can.
And then it just goes to show how much of the issues we're grappling with on the psychiatric front lines are representative of societal and cultural issues. And therefore, to some extent, psychiatrists can and should do what they can to improve the quality of care. But it does seem like it's going to take action at a collective societal level, really, to tackle meaningfully.
It's a political thing. Yeah, absolutely it is. Yeah.
Is there a place people can go to access some of the resources like the gift box that you mentioned?
Yes, there are a couple of websites. There's a new one being launched as we speak, which is going to be sort of becoming better in the coming days, which is called the gift box. But we can maybe put the links on your website. There's also links to the Talk That Heals website, which has Josephine's work on narrative and information about our book and little videos about the gift box project that we've done. So yeah, those would be the ones.
And I could see your book is available on Spotify.
Yes.
And I'll also post a link to the Amazon link so that people can find it there. Patte, it's been great to speak with you and to get some of your insights. Thank you so much for joining me today.
Well, thank you very much too. That was a lovely way to spend the last hour. Thank you.